Dr. Cerise. He is the President and Chief Executive Officer of the Parkland Health and Hospital System. Prior to coming to Texas, he actually was a secretary in Louisiana for the State Department of Health and Hospitals, which had, in addition to Medicaid, also the big public hospital system many of you are familiar with, of course, in Louisiana. He served as Associate Dean for Clinical Affairs at Louisiana State University. And among his many duties throughout his career, he also serves on the Medicaid and CHIP Payment and Access Commission, known as MACPAC, and that is a federal statutory commission that advises Congress on Medicaid and CHIP. So a very important and influential group. He has a ton of other incredible experiences. I'm not going to read them because I know you want to hear from him, but I do want to say we had the chance to have dinner last night, and dinner lasted about 2 hours, and at the end of it I said, Dr. Cerise, in the 2 hours that we've been together, how many people do you think have been admitted to the Parkland emergency room? And he did a little quick math because he's a doctor and you know they can do all that in their head. And he said, which is good, he said about 120. And it is actually one of the busiest emergency rooms in the entire country. So I can't wait to hear his presentation. I know you're going to enjoy it. And with that, Dr. Cerise.
Thanks, Donna.
You are welcome.
Okay, thanks, Donna, and good morning.
And the clicker handoff.
Oh, perfect. All right, well, thanks for the opportunity to talk, and welcome everyone. So I am going to talk about something that I find when Donna and I talked about, you know, what should we discuss this morning. I can't avoid this topic. You know, last month we had one of our fellows had our first morbidity and mortality conference, which shows you in health education. We have these M&M conferences where we review cases and examine what went wrong. And usually it's around a diagnosis that was delayed or missed or some part of the therapy. And this M&M was focused on social determinants of health, and that is looking at bad outcomes and then going backwards to see what sort of social issues contributed to that bad outcome. And she reviewed 2 cases, one a death and one a significant adverse outcome that were significantly influenced by the fact that these 2 people did not have insurance, didn't have adequate access to care, and that resulted in these poor outcomes. And so it's something that we deal with at Parkland all the time, and it's something that all of you who are in healthcare, whether you're in the safety net system or otherwise, it's something that's becoming more and more relevant to the work that we all do. It's getting a lot of national attention these days, healthcare costs and the impact on patients and families. And so you've seen, if you read this news, you see these stories now. Nursing homes suing family and friends. Is this hospital, the hospital everyone loves, is that driving up healthcare costs? Drug prices contributing to this. The Texas Tribune ran this story by Noam Levy. I know, Steve, you talked to Noam, about people going into debt because of their medical bills. And the fact that in Texas, I don't know if you probably can't see this well, but this is the 20 most populous counties in the US, and the percent of people who have credit reports who have medical debt on their credit reports. And those dots to the far right, those are the highest debt counties. That is Tarrant, Dallas, Bexar, and then one more over, I think you get into one of the other, Austin in there as well. So medical debt around the country is a huge problem. In Texas is a problem. I don't think it's any coincidence that Texas also has the highest uninsured rate in the country, and those things kind of go together. Where is the spending happening? Well, it's all the sectors. And the big blue is hospitals, the red is doctors and other professionals, and then you've got dentists and drugs in there as well. But it's across all sectors. But hospitals are getting a lot more attention these days than we've gotten in the past. The New York Times is running some issues now, one on a hospital chain that takes advantage of the 340B program and is not reinvesting in that hospital. That's an issue that Congress has their eyes on. I was down there a couple of years ago testifying on the 340B issue, very important issue to the safety net hospitals like Parkland. And as Congress looks at the program in its intended use, and they look at stories like this and say, 340B is a program that's out of control. We ought to do away with 340B. Not necessarily the case, but these things are getting a lot more attention now than ever before. And if you read the New York Times over the weekend, another one about hospitals hounding patients to pay. So my point is that there's a lot more attention given to this issue now than ever before. This was in New England Journal Catalyst, where they talked about price discrimination, deepening racial inequities, and the gist of this story was that that hospitals that can negotiate better prices and have higher payment rates are able to reinvest more, and as they reinvest more, they become more attractive and need to be in network, and as they do that, they have better negotiating power. And their point here is, in this quote, is that this is not, I say, well, this is just a market issue and the market should work this out. This was a stunning statement in that article, and that is, by 2026, the CBO expects federal subsidies for employers' plans alone to exceed all federal spending on Medicaid and CHIP. So this is not just a private market issue. This is the entire government issue. This is Medicare, CHIP, and federal subsidies for payments. And so this is the kind of thing where it affects all of us, whether it comes in the form of government payments, whether it comes in the form of premiums for insurers. And so with that as a backdrop, this sort of the pressure is rising, right? People are frustrated with rising costs and inability to access care, and you're seeing more and more of attention given to this topic. We are in a reality where it's a tough market right now. Everyone, certainly in the hospital business, and I know in other sectors as well, are dealing with the fallout of the pandemic and the wage pressures and the pressures coming from the increase in contract labor and difficulty filling your positions and having to rely on contract labor. So this is a slide that shows the difference in wages between salaried and contract people from before the pandemic to post-pandemic. And you can see the blue line on the left is the staff salaries and the green is the contract. And before the pandemic, it was about 2 to 1. Now it's over 3 to 1. I don't know how you explain this other than contracting agencies taking advantage of the pandemic to be able to charge higher prices, and hospitals are feeling it. If you look at labor expenses as a percentage of your overall costs, you see how that has gone up since the pandemic, and then just labor expenses in general. This is not just a hospital issue, it's sort of every industry is feeling this, but significant increase in your wages as a percentage of your overall expenses. So, I don't know if any of you read Tom Robertson. He has a blog. He was with the Vizient Research Institute, and he describes this issue of pricing and costs in healthcare. And he related it to the tragedy of the commons, and you probably know this story. It's the common area where the cattle could graze, and you may have several different farmers that are using this common space, and it can only support so many heads of cattle. And if you add one more, well, that might be an incremental advantage to that farmer that can now support one more cow on that plan, but on that patch. But over time, it cannot support the growing herds, and it will deteriorate, and then all of the farmers will suffer. And so this is the tragedy of the commons. Adding one more has its incremental advantage to that individual, but not to the commons. And so he relates some of what's going on in healthcare now to the tragedy of the commons. And he says, as long as health systems consider increasing market share, revenue, and operating margins as their measures of success, then it's perfectly rational to negotiate the highest prices in the private sector that they can. And there's a lot more behind this and sort of a discussion of prices in the healthcare sector. But this really caught my attention. He says, we are fast approaching the point where healthcare spending will exceed the carrying capacity of the middle-class working family's income. So it's no longer a problem of just the low income. He says we cannot slow the rate of increase in healthcare spending sufficiently by curbing utilization. If they haven't already done so, prices are on the verge of eclipsing the middle-class household's ability to pay. The market has failed to rein in healthcare prices despite 40 years of trying, and the indisputable failure of the market to deliver sustainable pricing suggests that rate regulation may not be as far off as we once thought. Now that's a sobering thought right there, but if you read Tom Robertson, he is just spot on in so many of his analyses, and I'd recommend people looking at his blog. But why does he say this? I mean, that it's eclipsing the middle class's ability to keep up. Well, this is a depiction of premium increases compared to wages and overall inflation over the past 20 years. It's a pretty dramatic spread in those graphs. If you look at the overall cost of premiums over time, and Kaiser does this this annual employer-sponsored insurance survey. It actually will be coming out again in October. But you'll see the premiums for family coverage have now exceeded $22,000 a year, and the family's portion of that is about $6,000 a year on average, some higher, some lower. And when you ask employers about this, as they did with the Pacific Business Group on Health, or it's now, I guess, the Purchasing Business Group on Health, but they asked over 300 employers with over 5,000 employees, so these are big companies that they're asking, that do you believe that the cost of providing health care benefits is unsustainable, and that is there a need for greater government role and coverage? Overwhelmingly, they say yes to those questions. What share believes that a greater government role in providing coverage and containing costs would be better for my business, would be better for my employees? Overwhelmingly, they say that would be better. So they're asking for more government intervention in healthcare costs and coverage. Big businesses. So it's particularly an issue for individuals, people who work for small employers. And if you look just over on the right side of this is the family coverage, and the dark is the employer contribution, the light blue is the family contribution. And you can see the graph of the tall three graphs. The one on the left is small firms, and the one in the middle is all large firms. There's about a $2,500 differential there for the family contribution between small firm and large firm. So if you're working in a small firm defined as less than 200 employees, you're going to pay significantly more, a higher share of your premium. And then if you look at the bottom section here, this is family coverage, and the percentage of the premium paid. The dark blue depicts people that pay over 50% of the premium themselves. That's the employer responsibility. And see that 31% there? Over 3 in 10 people who work for a small employer are paying over $10,000 a year for their premium. That's their share. That's the premium. This is the percentage of people who are paying at least $2,000 in deductibles over time. And so again, for the small firms, over 45% of the people are paying over $2,000 in a deductible. Now let's look at what people make. And so this is the average bank account. If you look to the left of this graph, the left two sections, that's going to be the bottom 40% of income. So 40%. That bottom 40% has less than $2,000 in the bank. So when these individuals say they can't afford health care, they can't afford health care. If you have less than $2,000 in the bank and you have a $2,000 deductible, you can't afford to get sick. And so I know people in the business are experiencing this with people that can't afford to pay. And so Kaiser asked just this. They said, who would be unable to pay if you had an unexpected $500 medical bill? The total line is on the top, but you can see roughly 50% would not be able to pay or would have to go into debt to pay a $500 medical bill. It gets worse for the low-income people. It gets worse for blacks and Hispanics. Who does have medical debts? 4 in 10 say they have medical or dental bills that now have caused them to go into debt. And a third of them have said that they've skipped care, or a family member has skipped care because of medical bills. So I got a call about 2 weeks ago. So just, to say how this happens. I got a call from somebody who said they were working with this woman who was pregnant, and she needed to get prenatal care. She needed to get an ultrasound, get into care, but she was not eligible for any program. So I called her up. I said, well, I'm sure she's eligible for something. Let's find out what's going on. And I called her, and she's 19 weeks pregnant, and she told me she was avoiding going to the doctor because she couldn't afford to go to the doctor. She had a job, was making $18 an hour, and which was too much to qualify for Medicaid. She's a DACA person, so not eligible for Medicaid, but would be eligible for the Medicaid CHIP benefit for the unborn child, but $18 an hour is too high. So I said, well, surely we can get you into Parkland. And well, she doesn't live in Dallas County, so that's a problem, although we do see a lot of out-of-county people. But you can see how these things stack on each other. Well, ultimately, she had hyperemesis, other complications of pregnancy, was not able to continue to work, and so without income, she was eligible and is covered with Medicaid, but not really the way that you want to get covered for insurance, right? And so this is one story, but these happen now. You all know these happen over and over and over again. And so why does it happen? Well, if you just look at how much these the people that are working today in sort of common sectors are just not making sufficient income to, or they're making more income to qualify for Medicaid, but not sufficient income to be able to handle the kinds of premiums and the kinds of deductibles that I talked about earlier. And so where is this leading? I talked about earlier, that there's much more emphasis right now on the cost of healthcare, whether it's drugs. You've seen Congress act on drugs just recently, albeit marginally, but it's a significant step into that space where they're going to negotiate prices in the coming years for Medicare. And you're seeing much more heightened attention around hospital pricing as well. These are just some examples that you already have seen. Some of them have been going on for some time now. Global budgets in Maryland are all-payer system. That's been going on for some time. Price regulation, price setting, Medicare fee schedule, that's an example of that. You hear the discussion of Medicare for all, not as hot as it was maybe a year or so ago, but I don't think that sort of conversation has gone away, and it's because of what I just described. It was one thing when this was a problem of the poor, and we had Medicaid to cover it, and the debate has been around Medicaid expansion and expansion states and non-expansion states. But what's becoming more and more prevalent is it's well past now a problem of the poor. It's a problem of the middle class, and perhaps even beyond at times. And so you're seeing heightened attention to the need to do something about healthcare costs. So let me just stop there because I want to leave time if people want to talk, and Donna, you want to talk. But in summary, as Tom Robertson said, the market has failed to achieve equitable and affordable access to healthcare. It's just we like to imagine that the market is kind of the fix for this. But we've got this cognitive dissonance in this country. If you ask people, they say we should have coverage. We want to have an equitable healthcare system. We want everybody to have access to care. And then we rely on this market system or this semi-market system to do that. And that's not what markets are designed to do, right? Markets are designed to create disparities. Markets ration goods based on people's ability to pay. So why would we think that that's going to be able to result in an equitable, accessible healthcare system for everyone? But that's what we've been struggling with for a long time right now in this country, and it's becoming more and more obvious as things get more expensive and more of the population is impacted by this failure that it's getting much more attention. So cost is no longer an issue only for the low income. The middle class is becoming much more widely impacted as well. The public frustration is rising. You've seen the newspaper. You're going to see more and more of those types of articles coming out and pressure there. You see a lot of projects around cost. You hear it on NPR. The case of the month or case of the week or whatever, where they talk about healthcare bills. So the pressure for regulation is growing. I don't know when that translates into something more widespread, but there's this tension right now about the need to do something and the resistance against government intervention and price setting and that sort of stuff. And so I guess what in the meantime, the light's going to be shining on all of us, and what we can do. And I know there's a lot of good work that goes on out there, and it's just going to be sort of a heightened need to be sensitive to that dynamic now, and as individual providers and systems to do what we can do to take care of the needs of patients and try to avoid those horror stories that you see reported in the paper of people being sent to collection and financially ruined. It's a fact of life. I mean, if you look at personal bankruptcy, medical debt is the leading cause of personal bankruptcy in the country. It's a fact of life, but as providers and systems, I think we need to be attuned to that in our own policies and look at how we can kind of mitigate some of this impact while this bigger picture sorts out. So with that, Donna, I'll open it up if you want to talk or if people have questions, I'll be happy to answer them.
Thanks, and you can have a seat if you'd like. So.
Okay, I'll do that.
Well, Dr. Cerise, thank you so much for a compelling and sobering and fascinating presentation. We will open the floor up for questions. We've got about 10 minutes, but it's interesting. Earlier this morning, I was talking with some gentlemen here, and we were talking about this very issue, how hard it is to control the cost of health care. To me, one of the biggest issues is that everyone's about market regulation, but they need an exception for their self or their family or a friend, right? Because there's this personal stories and personal aspect to healthcare that make it very difficult to control costs. So if you had like the proverbial magic wand, what would be, several things that you would either do or you would ask the people in the audience to do to try and start to get a handle on the cost of healthcare?
Well, Don, it's such a difficult question because I think if our goal is to have equitable access to care, and I don't know that that's everyone's goal, right?
Agreed.
But if that's our goal, then it really does call for a totally different structure than we have today. And you can, I think the Affordable Care Act was a good attempt to get there. As you know, it kind of got pieced apart,
right.
And so there became some pretty big gaps in that plan. The option of states to do Medicaid expansion was obviously one big piece of that. The loss of employer and individual mandates, those things that have to go together to ensure that everybody that's not in the public program gets coverage. And so I think I think that was a really strong attempt to get everyone covered. But if that's your goal, you have to lay out a system where everyone can get care according to their ability to pay, and that there's some control of the provider system in terms of developing the appropriate capacity to meet the demand. So things like global budgets is one of the things that would get you there, where you look at the population and you kind of identify what sort of capacity you need to meet that, and then you could work with the private sector and to identify paying. I think all payer models are a version of that, an attempt to get in that direction. But it really does call for more dramatic changes, which is why I'm not optimistic that we're going to get there. You might get forced into there. You could get forced into there with things like Medicare for All, which I know a lot of the hospital systems and other providers don't like because they don't like the Medicare rates. But it does it would pull more people into the system and put more, it would put more pressure on prices and whatnot. So, those are some areas I think, you might see more shakeout with this wage issue, because what you're seeing now, and I don't have the data on this, but there's a lot of anecdote out there now about hospital closures, smaller hospitals, rural hospitals, hospitals that don't have the ability to weather that wage storm that we're going through right now, and the loss of providers could provoke more kind of regulatory action on what we can do with wages and reimbursement. But short of if you want to cover everyone, you have to design a system to cover everyone.
Right.
And that gets very radical in this country because we've rejected that for a long time. Even though every other developed country has a universal system. Some of them rely on insurance. Some of them rely on a public delivery system like the NHS. Some of them rely on a government supported system like Canada. There's versions of, the U.S. has a piece of every one of those. We just don't have one that comprehensively does the trick.
Right. The other thing that I know Parkland was at this, one of the epicenters on COVID, and it seems that the COVID epidemic put a spotlight on not just this issue of the cost of healthcare, but disparities by race, the labor shortage, the cost of care. Tell us just, it could probably be like an entire hour on what it was like to be running Parkland during COVID, but I'd be interested in some highlights, maybe some things that you're looking at now that you've learned, and then we'll open the floor up for questions.
Yeah. Well, that what you learn in these crises, whether it's COVID or whether it's a hurricane or whether it's some other disaster, is that the baseline disparities get amplified. And so there's a long history in why we have these disparities, but the fact is that they exist. And so around the country, what you saw was just you saw them exacerbated by either the distribution of where services were, and so people that have access at baseline are going to have access during COVID, and those that don't have access at baseline are going to have a tougher time getting access, right? Dallas, I think, is fortunate. The systems here work together well. We worked with the public health system here very well. Steve Love and I are part of a group that meets regularly to look at how we're doing as a county on this issue. In a lot of areas, you don't have that same coordination.
Right.
And so the places that have poor access at baseline then had poor access to testing and to vaccinations, and it was more challenging like that. And that tends to play out and get amplified during disaster. So you have to be intentional if you're going to act and try to break that. Then you have to be intentional about where you're going to put your services. And we certainly did that in Dallas, where we focused a lot of our relief services down in the southern sector, where you don't have traditional concentration of providers and other health resources.
Great. Thank you. We've got about 3 minutes left, so questions from the floor. I can't see really well, but I'm confident someone is dying to ask something. So over there, thank you.
Hi, we're controlling it centrally, yes. Thanks very much. I'm Bill Sage, just came up here to Fort Worth from UT Austin. Just following up on your question, it was striking, most of the things that you describe are long-standing. It's very much actually a 1992-93 moment for most of the things that you identified, which was interesting to me. You didn't, other than contract nursing, talk about the pandemic, and then you just got this nice question about the pandemic. If you could just pick one lesson from the pandemic that applies to the major issues that you were discussing, I'd love to hear it.
I think something that has come out of the pandemic that has fueled those slides on contract labor is a well-intentioned federal relief. And so when this thing started in New York, and New York needed healthcare help, and people from around the country started mobilizing, and who could go and help in New York when this thing started. That was how we're used to dealing with disasters. It's in a localized area, you flood it with resources, people go in and help out, and then over time it goes away and people go back home. But that didn't happen, right? So it was New York, and it was another place, and it was the whole country. And the federal government was trying to provide relief, and so flooded the market with money. And you saw like in states like Texas, where Texas at the state level was spending federal money to put contract nurses in hospitals because everybody needed nurses. And it fed on itself. And so a contract nurse would come into Parkland and work next to a staff nurse and say that I'm making 3 times what you're making, and here's the card of the agency, and this is how you do it. And so I learned a new term during the pandemic. It was single no animal. And a nurse who was a single no animal could pick up and move, and that's what they did. And so when you picked up and moved, then you created more staff need at the hospital, right? And you had to fill that with a contract nurse that was then being generated from another hospital because of the high rates that the federal government was paying. And so if there's a lesson there, I mean, the common theme is, when somebody else is paying and you're spending, there's less pressure to kind of, or less, pressure or whatever, motivation, but pressure to keep the price down. And it just spiraled, and it was fueled by well-intentioned federal money, but it went up and up and up. And I didn't, when Texas, the state said, how many nurses do you need? I looked at our staff and I said, this is what we need. And they sent them, and they were spending federal money. So I'm sure they were paying the agency whatever they had to pay them to get those nurses because they wanted to provide relief, right? And now we're in this situation that just, we've set a new baseline. And I'm afraid it's going to take some time to normalize.
Please join me in thanking Dr. Cerise for his time.